Good afternoon. Thank you for coming. My name is John Petit, and my colleagues and I at Dana-Farber and Brigham and Women's in Boston are looking forward to exploring with you what for us is a live issue: demoralization, learning challenges, and opportunities. I'll begin with a brief overview, and then we'll have my colleagues who will introduce themselves lead a discussion of 4 cases illustrating different educational challenges in this area. I have the following disclosures. So, one educational challenge that we often face is to help a trainee deal with a request to see a debilitated medical patient, often in pain, who has expressed SI and may have asked the nurse to just shoot me. The consulting psychiatry resident typically proceeds through a depression symptom checklist and risk assessment, presents the case as a patient who meets only some criteria for major depressive disorder, seems more passively than actively suicidal, and does not seem motivated for medication or a referral for psychotherapy. The resident diagnoses adjustment disorder with existential distress, but is unsure how to proceed next. Part of the challenge, of course, is clearly distinguishing demoralization from depression. Demoralization has been increasingly recognized as a common syndrome reflecting overwhelming existential suffering, situational helplessness, hopelessness, thoughts of giving up. Remains challenging for medical staff and psychiatric trainees to assess and treat. Has a prevalence of 13 to 18% in patients with cancer and other progressive illnesses, and has sparked a number of papers in the literature about how to deal with it. Historically, we've had Engel and Smalley describing a phenomenon of giving up, Seligman talking about learned helplessness, Jerome Frank talking about the importance of meaning and not having meaning in medical contexts. But the person who's done the most work in recent years on demoralization is David Kassane, who was at Memorial Sloan Kettering and has been in Australia. And he's responsible for a good bit of the literature about demoralization with diagnostic criteria that you can see here. Emotional distress, such as hopelessness and loss of meaning and purpose in life. Helplessness, failure, pessimism, lack of a worthwhile future. Reduced coping, social isolation and deficiencies in social support. And a persistence in 1 to 4 of these across 2 or more weeks in a patient not meeting criteria for major depressive disorder. And he's also described demoralization on a continuum from disheartenment, despondency to full-blown demoralization with a loss of meaning and purpose. And he's also published about a validated 24-item self-report instrument using a 5-point Likert scale for assessing demoralization. But what about treatment options? We know from Wiedemann and Perry about the importance of taking a life narrative in a medically ill patient. Jerome Frank, as I mentioned, has written about the restoration of morale. We sometimes engage in bedside psychotherapy targeting existential and spiritual concerns, which overlaps with work of our palliative care and chaplaincy colleagues. Bill Breitbart and others have developed formal meaning-centered psychotherapy based on the work of Viktor Frankl. Lethberg and others have developed meaning and purpose therapy. Harvey Chochinov has developed dignity-promoting therapy. And James Griffith at GW has described hope modules, which I'll come back to in a moment. And at this meeting, I noticed that Lisa Park has a session tomorrow on resilience in patients with life-threatening illness. And then someone else has a session tomorrow on the use of ACT in the CL setting. I wanted to spend a little bit of time on James Griffith's HOPE modules because I think they're probably the best described, most directly applicable to the CL setting. In his 2017 paper in Academic Psychiatry, he encourages us as clinicians to help patients conceptualize hope as a practice, adopt a framework of resilience, and assess coping during adversity. What helps you in hard times? And he suggests 4 primary strategies focused on number 1, problem solving and goal setting. Number 2, emotional regulation. Number 3, activating a core identity. And number 4, enhancing relational coping. By individualizing assessment, you can tailor an intervention based on these strategies. So in our setting, we found it helpful to talk about existential concerns and approaches to these on rounds and in supervision. But we frequently encounter, sorry, I'm going backwards here. We frequently encounter some obstacles when it comes to teaching about this area. One is an over-identification with the patient. Anyone would be depressed in this situation, so what can I have to say to them? Inexperience is a big factor. There's sometimes a pathology and biomedical orientation. The trainee sees their job as making a DSM diagnosis and a disposition that may be what they're more used to, along with a risk assessment. And then along with that, a lack of familiarity with the interventions that are useful outside of settings favorable to formal psychotherapy. But when residents are exposed to some strategies for recognizing and fostering resilience, they often find them valuable. This is a quote from Griff's paper, HOPE Modules, from a resident. I've used HOPE modules in community clinics. This is a population that often lacks the opportunity to talk about and reflect on their own strengths and resiliences. Case managers often talk with patients by dictating what they should and shouldn't do. I realize that the way I talk with patients is very different due to the HOPE module philosophy of eliciting strengths. So next in this workshop, we're going to have 4 cases discussed, which exemplify different educational challenges in this area. And look forward to learning from them and from each of you as we have an interactive time together. Damian Myron is going to describe the first case.
Hi, everybody. Thanks so much for coming. My name is Damian Myron. I'm an attending psychiatrist at Dana-Farber Cancer Institute and Brigham and Women's Hospital, and I'm the director for Dana-Farber's Inpatient Psychiatry Consult Service. I'll be leading us through the first case today. Like Dr. Petit mentioned, demoralization is a difficult disorder, a difficult clinical scenario for patients who are admitted on oncology floors and throughout the hospital and also in the clinic. So it's a very difficult challenge for trainees who are seeing patients in different settings to learn more about demoralization and figure out how they can help these patients best. So like I mentioned, I'll lead through the first case. This case is somebody who was recently admitted to our inpatient oncology service, and the inpatient psychiatric consult team was consulted on to follow, and we'll jump into a little bit more. For the sake of this case, we're going to be trying to take an approach of as if we are the CL psychiatry fellow who was consulted to see this patient on the floor. So we'll go through it with that sort of perspective. And we'll stop at a few points and I'll ask questions. We can kind of put our heads together to think more about the case. I don't have any disclosures to reports. So jumping into the case, the patient is a 56-year-old man, originally from Puerto Rico, but moved to Boston about 20 years ago, fluent in both English and Spanish. He was a Navy veteran. He served for a few years in his early 20s, and he has no past psychiatric history to note, and has a family history of depression with 2 completed suicides in remote family members, 1 uncle and 1 remote cousin. And he has no significant past medical history, but was recently diagnosed, or a few years prior to our consultation, with multiple myeloma, and he is now currently admitted for CAR T-cell therapy. Our psychiatry consult service was consulted on the 10th day of admission with the consult order, quote, patient significantly withdrawn, endorsing depression/anxious mood, would benefit from psych eval and management recommendations. So I'm going to go into a little bit of detail about this patient. I'll go through chronologically. During our interview, the patient was able to provide a history of recent events, but this is sort of compiling a few different interviews that we had with him into one more consistent narrative, just to make it easier for us to kind of talk more about him. So in 2017, I mentioned the patient's originally from Puerto Rico. Most of his family is still living there. And in 2017, he had 2 family members die during Hurricane Maria. They actually had been on supplemental oxygen for several years and died in the aftermath of the hurricane, after power outages turned off their supplemental oxygen. So they weren't able to get their oxygen, and then they died as a result. About a year later, in 2018, the patient took an early retirement that had been planned for many years. He worked in business and had planned to take this retirement for some time, and was very proud to have been able to retire in his early 50s at that point. About a year later, he had hoped to visit family in Puerto Rico and help them just continue their recovery from the hurricane. But unfortunately, at about that time, the pandemic started, the COVID-19 pandemic. So he wasn't able to visit them, and he had to basically stay isolated in Boston, like many other people had to at the time. Not long after that, in 2020, he presented with extreme fatigue and weakness and was diagnosed with multiple myeloma. And he underwent multiple lines of chemotherapy and immunotherapy, but unfortunately did not achieve remission at that point. So he underwent stem cell transplant in September 2021. That transplant admission was very difficult for him. It was a very prolonged admission. The admissions in general tend to be prolonged for stem cell transplant patients, but for him, it was especially difficult. He had severe nausea and vomiting, and it was a very difficult course for him. Unfortunately, and he underwent the routine post-stem cell transplant follow-up. He had his labs checked periodically, was meeting with his oncology team fairly often. But unfortunately, in June 2022, there's a typo on the slide, but June 2022, he was diagnosed with multiple myeloma, with the relapse of his multiple myeloma. And that was just through his routine monitoring. He was feeling fine at the time. His initial presentation was for severe weakness, but at this point he was feeling okay. But it was still devastating news for him to get, not even a year after transplant, to find out that he had relapsed. Within a month of that, July 2022, he presented with severe low back pain and had to undergo an urgent laminectomy of L3 and L4 for a bulging disc. That was not a complication of his multiple myeloma. That was just totally unrelated, just by chance happened to happen at the same time within a month of his being diagnosed with the relapsed myeloma. Unfortunately, that procedure was complicated by chronic urinary retention, and he has needed a Foley catheter since July when he had that procedure. And he also had persistent sensory loss in his upper thighs and his genitalia. So he lost all sensation in July 2022. And then moving ahead to just about a month or two ago, October 22, he was admitted for planned CAR T-cell therapy. That was when we met with him. As I mentioned, the CAR T-cell admission was planned for some time. It was on his calendar. He knew it was coming up, but at the time of diagnosis, he was diagnosed with urosepsis related to his chronic Foley catheter use. So his treatment was delayed. He had to undergo antibiotic treatments and was monitored for several days on the units with infectious disease following, but eventually was able to start his chemotherapy in preparation for the CAR T-cell therapy. And at the time of our consult, he had not yet had the CAR T. It was a few days away. During his course, he was found to have a new onset of tongue fasciculations and new gait unsteadiness. He underwent a head imaging and more workup because of those symptoms, but the brain imaging and other testing was unremarkable at that point. But throughout his course, there was increasing concern that he had become more and more withdrawn from family, from his treatment team, and just was not engaged in the same way that he had been on admission and what was typical for him in the past. When we met with him on the units for our initial psychiatric interview, he reported strong feelings of hopelessness and helplessness, death wishes, and passive suicidal ideation. He reported neurovegetative symptoms, and he told us that at times during the mission, he would pray that, quote, God be merciful and take him away, meaning that he would die of his multiple myeloma. On exam, he was fully oriented, and he was somewhat distractible at the start of our interview and was looking to the door of his hospital room often as people were coming and going, and he was very focused on the nurse as they were hanging different lines and starting different treatments. So he wasn't always completely focused on us throughout the interview, especially at the beginning, but on formal cognitive testing, he did okay with attention testing. And on physical review of symptoms, he reported severe fatigue, headache, persistent nausea and vomiting, which was active and present at the time of our interview with him, and was also impacted his ability to engage with us. He's feeling very nauseous. And he also has, as we know, his chronic urinary retention and tongue fasciculations. So I'm going to pause here just for a minute or two. Knowing what we know about this patient so far, I'm curious, what would be on your differential if you were the person taking care of this patient, if you were the CL fellow in the room, what would be on your differential diagnosis for this patient, and what other information would you want to know about him before making a diagnosis and moving forward with your treatment? And we have a microphone up here, and we also have another microphone too that we can walk around. But does anyone have any thoughts about so far, knowing what you know so far? Depression. Mm-hmm. Definitely would not be an uncommon question on the inpatient unit for a patient to experience depression. Anything else that people are thinking of? Mild delirium. Mm-hmm. What makes you think that? Distractibility. Yeah. Any other information that you want to know more about at this point before taking next steps? The question was, what did Neuro think about his tongue fasciculations and his unsteady gait? So Neuro had just gotten involved at that point within a day or two. They hadn't made any final recommendations, but they did the brain imaging, which was reassuring to them. They didn't have any other firm diagnosis about what could be causing it though. And I guess looking ahead of the rest of his course, that did go away after a few more days. So it wasn't something that we ever had a firm, clear idea of. They think that it was maybe medication related, but they weren't exactly sure. Unfortunately, that's a good question. Great. So just kind of thinking through different things that we were thinking about after seeing this patient. So demoralization was one thing that we thought about. He had, throughout the entire interview with him, there was a strong sense of, or a strong theme of the loss of control, the hurricane, him having this multiple myeloma diagnosis, which came after really a lifelong history of no significant past medical or past psychiatric history. He had not engaged much with the medical system at that point in his life. This is back in his initial diagnosis. And then undergoing multiple lines of treatments, which did not succeed, undergoing the stem cell transplant, which he had hoped would be a final treatment for him, that he wouldn't need to get any more treatment in the future. He knew that it was possible that he might relapse, but I think, as a lot of our patients, he thought that things would go okay after the transplant and that there'd be a lot of follow-up, but he wouldn't necessarily need, he wouldn't have a relapse as soon as he did. He told us often that he didn't last a year until he relapsed, and how frustrating that was for him to go through that difficult admission only for 9 months of his remission. And then also with the loss of control, having the chronic Foley catheter and the loss of sensation that he had just really adds to his sort of loss of bodily autonomy that he was experiencing. And plus just the ongoing severe physical symptoms that he had. When we were talking with him, he mentioned that he's someone who does not do well when he has strong physical symptoms, whether it be pain or, for him, through most of these admissions, really severe nausea. Delirium was also on a differential. There were the concerning distractibility, the new neurologic symptoms, the gait instability, the tongue fasciculations. It was reassuring that he had no significant imaging findings on initial workup with the neurology team. But that was another thing that we were worried about and something that we tracked through the rest of his admission course. Unfortunately, he did go on to get his CAR T cell therapy within a few days after our evaluation with him, and he did go on to develop delirium later on, but we were still worried at this point that there may be a mild delirium in the background, though he did well on cognitive testing, which was reassuring. PTSD, he, both from the medical trauma that he's experienced, this traumatic past admission at the time of stem cell transplant, and also he reported his history of Navy service was also something that was on his mind, and he talked with us a little bit about that in the initial interview. But that was just something else on the differential. Primary depressive disorder. He has a strong family history of depression with 2 completed suicides in the family, and then of course adjustment disorder as well. So I think he, like a lot of patients, fits into a bunch of different categories, and I think highlights how difficult these courses can be for a lot of our patients. And in demoralization, people who undergo multiple repeated stresses, like one after another, they can kind of tend to accumulate for patients and lead to this loss of meaning or purpose, a sense of failure, a disheartenment, or feelings of helplessness and hopelessness. And this is definitely true for our patients. He was very excited to have retired early, but then instead of going to work, as he had been working hard, and instead of going to work every day that he had been for many, many years, he was expecting to go into retirement and do what he had always wanted to do, but then he got hit with these multiple medical problems back to back, and he was basically in the medical center very, very often. And for a patient to undergo so many lines of treatment that at the beginning you're kind of told, like, oh, this is going to go well, like we're going to try this next chemotherapy, next immunotherapy, we think it'll work, but then have so many treatment failures, it just can be very demoralizing for patients. And that was definitely true for our patient. And then jumping ahead further later on in the admission, at this point, he doesn't have any delirium, but you're going to go, you as a CFL are heading to the room to do a follow-up assessment, and the team is outside the room. They pull you aside and say, the patient isn't really letting us do what we need to do with him. And you talk with him a little bit more, and they're saying he's refusing vital signs. He's refusing his medications at some points, but then he'll agree to take them later on. And he's not engaging with physical therapy as much as they would want, although he does everything that they want him to do eventually, just not kind of on their schedule. So then my last sort of discussion question, what advice would you have for the treatment team for a patient taking for a treatment team who's taking care of a patient like this, and a team that's struggling to engage a patient in their sort of treatment plan during their admission? And I think this is a common thing that people run into. Does anyone have any ideas of what usually they find helpful for engaging teams like this? Establishing common goals. What kind of goals do you mean? What does he want from the hospitalization? What does the team want from the admission? Yeah. But I think that can be really helpful, like making sure everyone's on the same page, and they know, not only what is asked of the patient, but why it's being done, and making sure that the patient kind of understands and everyone's on the same page and has the same goals. The response was knowing how important autonomy had been for this patient. Is there a way for him to get some of that autonomy back? And that's one thing that we did talk with the team about at this point too, even just, curbsiding before we went into the room, is coming up with times, does he have any choices in when he gets things? Are there any negotiations they can do with physical therapy about how often they see him, when they see him, things like that give him a little bit more stake? Because obviously hospital admissions are not very, they run the hospital schedule, not the patient schedule, unfortunately. I think there was one hand. Okay. That was her response also. Great. Thanks very much, everybody. And I'll turn it over to Dr. Landerholm.
Hi, everybody. I'm Angela Landerholm. I'm an attending psychiatrist at Dana-Farber Cancer Institute. I'm going to take you through a case centered on helplessness, both as the kind of CL fellow or resident, and then helplessness in the team that you're liaising with. So I have nothing to disclose. So This patient is a young woman who you're consulted to see in the ICU. She's in her early 20s, status post lung transplant and kidney transplant, who has continued to be on ECMO. The consult comes in 5 months into her admission, and it's actually a reconsult because she was seen before transplant. Now the team is looking for recommendations for managing depression. They tell you that she's been more withdrawn, not participating in PT, seems to have low mood, and they're worried that this is really interfering with her recovery. So a little bit more about the patient. She was previously healthy, no psychiatric history, had just recently graduated college, started a job, in a relationship with her boyfriend, and came into the hospital with severe ARDS due to an unknown virus, complicated by stress, cardiomyopathy, and renal failure. She had a very complicated post-transplant course and ultimately was not able to be decannulated from ECMO and required ongoing ventilation and dialysis for quite a while. The team had already tried numerous trials of SSRIs, SNRIs. The list included Lexapro, bupropion, clonazepam, lorazepam, olanzapine, and even a trial of methylphenidate as well. At this point, when you, as the fellow or resident, go see her, on numerous evaluations, it's kind of hard to determine, is there delirium? Is this kind of intentional disengagement from care and interviews? At times, she rests with her eyes closed, not clear if she's listening, but choosing not to participate, or rather just kind of too sick. Other times she's more alert and makes statements like, how long do I have to live like this? I'm scared. Am I going to die? The team is very concerned about her depression, as we said, and they have been pursuing off-label uses of customized tracheostomies, kind of going to great lengths to work around barriers or obstacles that come up in her care and ultimately getting her off ECMO. They feel very strongly that she would benefit from IV ketamine infusions and begins IV ketamine without recommendations from psychiatry. It was pretty clear from the consultant perspective that the ICU team was really struggling with their own helplessness as well, in terms of how do we help this patient? How do we get her better? So I'd like to pause here as we think about helplessness and take a moment to brainstorm some possible internal and external reactions to helplessness. This case may remind you of cases you've had in the past that stir up kind of reactions to your own feelings of helplessness, or when you've been the consultant for a team who's struggling with helplessness. What internal and external reactions have you encountered? I'd like to ask, if you're sitting next to somebody, maybe we take 30 seconds or so to turn to your neighbor and think about, brainstorm some ideas, if that's okay. Okay. So maybe you could just call out some of those things that you've brainstormed, ways that you might respond to that feeling of helplessness. Any ideas? Go ahead. Definitely. Yeah. Yeah. What else? Yeah, it can be really hard as the consultant when you feel like you can't fix what they're asking you to fix. Oh, yeah, sorry. So the first one was avoidance. Feeling like there's strong emotions and so avoiding the patient. And then the second one was the countertransference as the consultant to the consulting team, feeling kind of frustrated that you're not able to fix what they ask you to fix. So this was kind of my brainstorm. And I think there's an important distinction about the external responses and the internal responses. I think when I think about the external responses, I think this could really impact team dynamics and kind of working together and taking care of the patient. And then when I think about the internal kind of reactions here, I think that it raises important questions about burnout, moral injury, and demoralization in healthcare workers and those, people taking care of very sick patients and feeling that helplessness. So the next discussion questions that I have, in the literature, you'll see that burnout has at times been described as moral injury plus demoralization. And I'm curious to hear how this might affect your practice and how you would help individuals or a team struggling with helplessness to care for a patient like this. And again, maybe I could ask that you kind of turn to your neighbors and brainstorm together for a minute or so. Okay. So we do have a microphone if people have like longer responses that they want to share and we have time to like run over with the microphone, we could do that. But I'm curious to hear what ideas you all came up with. Maybe if you raise your hand, we can run over with the microphone. And I'll tell you that I also will share my ideas too. So it's a give and take.
My experience with this has been that often the physicians or providers involved conflate grief and guilt and will express that they feel guilty that they're unable to alleviate the suffering of a patient like this as if they could somehow do so, when actually what they're doing is grieving, bearing witness to a tragedy. And so when I work with these kinds of teams, I'm usually trying to help them make space for grief, and not confusing it with guilt or even betrayal. The moral injury term is an interesting one because I think of moral injury as different from moral distress. And it's not clear to me in this case where there's been betrayal which is classically associated with moral injury. But there's no doubt that there is distress when we as providers can't offer the level of care we have hoped to in order to alleviate this degree of existential terror for our patients and ourselves.
Yeah, thank you for that. I think your words about bearing witness and trying to support our colleagues and each other in kind of tolerating some of that is, I think, part of the most challenging and rewarding pieces of our jobs. Got another one.
Hi. Yeah, your response brought up my question of like, how do you get teams to even talk about their emotional responses? Like even admitting guilt is something that I feel like I haven't heard primary teams bring up on the phone. Like you can kind of infer it, but yeah, how do you any of you kind of make space for the team to express their emotional reactions?
So I have included up on this slide some approaches, and one of the kind of simplest may just be kind of a team discussion, getting people in a room together, which has taken on a different form in the time of COVID and post-COVID Zoom technologies. But to your point, I think it's one thing to call a team meeting, but it's another thing to actually elicit people's own emotional reactions to their patients in those meetings. On this slide, I've pulled from a number of references that I found really helpful, and our references are all listed here at the end as well. If you'd like to circle back and read more about any of these strategies, they are not my own, but I think that they could be very helpful. So I can point out a few of them. The first is, to help patients balance and diversify their hopes, providing flexible future directions and possibilities, which may allow you to feel, or the team to feel, kind of less helpless and less hopeless in helping the patient see, various possibilities for their care. This was taken from the JAMA article, Holding Hope for Patients, which is, I think, a very helpful perspective. Another kind of strategy here would be, and maybe this is a good approach in a team meeting, to divide the overwhelming situations into more manageable components, which may make it a little easier for, the consultees that you're working with to tackle some of the feelings that they're having. And that brings me to the next one. The 4 steps: name the feeling, accept the normalcy of the feeling, reflect on the feelings, and consulting a colleague. We can also think about reframing helplessness. So, the goal would be to move from a place of defeat, humiliation, to acceptance, and then understanding the helplessness as a way of better understanding the patient. And this kind of harkens back to the analytic tradition, where if the analyst feels helpless, they may kind of enact certain external responses to the patient, and just being aware of those things. Another way to reframe the helplessness would be to kind of shift from either being hyper engaged or hypo engaged, like someone mentioned, avoidance of the patient, into a more kind of constructive zone of taking care of the patient. And then the last strategy that I thought was really helpful is this RENEW acronym. So kind of recognizing the feeling, embracing the feeling, nourishing yourself in whatever way, is most relevant to you, and kind of then embodying and weaving the helplessness into a reframed, more constructive way of relating to the team or the patient. So just a little snippet, but I thought that these were kind of helpful, tangible techniques to consider. So that is my part. Next, we will hear from Dr. Hermie Amanu, who was not able to join us here today in person, but we do have a recording from her that I will queue up right now.
So hello, my name is Hermie Amonu, and I am really excited to share a little bit about the learning challenges and opportunities that comes with managing
Is there a way to fix the slides so that hers also show here?
demoralization in patients at the end of life using the third case. So I have no disclosures to make. So in terms of this specific patient, we were privileged to be invited to care for a 70-year-old retired prominent professor who has a history of metastatic lung disease. And for this specific admission, came in for pneumonia and unfortunately rapidly decompensating pulmonary status. So during his hospital stay, he transitioned his code status from a DNI, DNR to comfort measures only. And immediately he made this decision, he started to have a lot of anxiety about the implications of being comfort measures only if his pneumonia and his pulmonary status did not recover. His anxiety got so worse that his oncology team felt we could help to manage his anxiety, especially if he was going to be rapidly end of life than they had anticipated. So on psychiatric evaluation, his mental status exam was pretty negative and overall was a very sharp elderly man. He was alert, he was oriented, he looked frail in the setting of his acute medical problems, and he was attentive and also really anxious appearing. Based on our evaluation, he did not meet criteria for a major depressive disorder or an adjustment disorder in the setting of everything that was going on and the acute onset of his symptoms. But we felt that he was having pretty significant existential distress about potentially dying from or during this hospitalization. So based on that, we, in addition to offering him some medications to help with his anxiety acutely, we thought it would be helpful for him to engage with our spiritual care team. However, patient was ambivalent about it, but his family was very adamant that he's never been a religious or spiritual person, and they would prefer that, at this point in time, they would not want him to engage with our spiritual care team, which we felt would have been useful considering some of the questions that he was asking about dying. He had questions like, what will happen when I die? Where will I go when I die? And what would happen to his family, which seemed appropriate to have some engagement with our spiritual care team. But because he declined that, we decided to engage him using brief psychotherapy, where, we acknowledged with him the profound loss that death and leaving his family entailed. We emphasized, the love and support of his friends and family, a lot of whom were at his bedside during this hospital stay. And we also spent a lot of time reflecting with him the legacy that, he's left with his family and his profession. He had actually accomplished quite a lot professionally and was well known in his field for things that he had contributed to science and his field in general. And we use this framework for helping patients manage existential stress, which entails like a 8-step process which starts with first connecting with the patient, which we had some time to do as part of our psychiatric evaluation. For this patient, he didn't really have any underlying psychiatric disorders, at least based on our evaluation. We gave him a lot of time in step 3 for him to share about his life, different things that he had done, to get to know him and his family in a robust way. In step 4, we acknowledged the stress of rapidly declining health, which wasn't anticipated, at least immediately prior to his coming into the hospital, and how threatening it was for him and with the potential implications of dying imminently. In step 5, we tried to engage him with some of the existential questions he had pertaining to death and what would happen to him when he died. We spent a lot of time in step 6, where we really reflected his strengths and resilience. This is a guy who had successfully undergone treatment for metastatic lung cancer, although he wasn't cured from his disease. He wasn't receiving active treatment at this time. And he actually said several times that, he couldn't believe that acutely it wasn't his lung cancer that was potentially going to end his life, but rather like a pneumonia and like a bad infection. So we really spent time with him, just acknowledging how resilient he was and considering everything that he had had to manage up until this point. In step 7, we tried to make a plan with him, make a plan after patient is not demoralized in such an acute setting. We didn't have time to wait for him not to be demoralized. And so this step may not necessarily apply to people depending on how acute their medical conditions is. And in step 8, we tried to also understand what the patient's values were. And in this case, his family was very much involved, and also tried to respect what their values were when it pertained to like spiritual care, although we felt that would have helped him manage his existential distress. Another tool that we've also found helpful in these cases is also reinforcing a sense of transcendence and meaning for patients. And you have to tailor this based on patients' needs and what their values are. So whether it was prayer and meditation that we know works well for some people, for this patient wasn't necessarily the case based on his values. There's definitely a lot of role in spending time identifying what brings patients meaning and purpose and what their overall calling in life. For patients who are acutely at the end of life, like this guy, you sort of had to tailor that to more or less reflect on what they had done in the past versus what they could do in the future. For patients who, again, weren't imminently at the end of life, encouraging them to engage with their community and various rituals. That sort of ties back to the second one on meaning, purpose, and calling. For some patients, charity and volunteerism is also important when it comes to helping them manage demoralization and existential issues in general. For some patients too, forgiveness, gratitude, and kindness can also be really useful, just as well as social justice. And the whole idea of acceptance of self and others can also really contribute to reinforcing meaning for a lot of people. And also really helping patients to realize that they are part of something larger than themselves can also really be helpful for patients as they navigate demoralization and existential suffering in general. So to sort of wrap up, we engage with this patient as much as we can, and provided some recommendations. And literally within 12 hours of our last encounter with this patient, who I actually had the privilege of working with I think I saw him around 3 p.m. on a Thursday. And when I came back into work around 7:30 a.m. to check in on him the following day, he had actually just passed away, and was able to spend some time with him and his wife, who was at the bedside at the time. And from what his team said, he responded really well to pharmacological intervention, and overall had a sense of peace immediately prior to passing away. Thank you again for the opportunity to share this case.
All right, so thank you everyone for your attention. I know it's the end of the day and it's freezing in here, so thank you for bearing with us. But this is the last portion of our talk. So my name is Stephanie Tung, also from Dana-Farber, Brigham and Women's. And we're going to talk more about medical student education and the role of the CL psychiatrist as an educator. So these are my disclosures. And we're going to start with another case. So you imagine you are a CL psychiatry fellow. I know some of you are CL psychiatry fellows, some are a little bit further out. So you get a consult for management of depressed mood in a young woman with metastatic ovarian cancer. She's had multiple medical complications, so recurrent malignant ascites, persistent small bowel obstructions, and multiple hospitalizations for spontaneous bacterial peritonitis. She has been very disappointed and frustrated by her disease progression and complications. And as a CL psychiatry fellow, you, as often occurs, are juggling a few different responsibilities. So in addition to caring for the patient, you are also involved in education. So you are supervising you got really lucky. You got an intelligent, motivated, empathetic medical student who assists you in caring for this patient. The student is involved in the initial assessment and diligently follows the patient during the hospitalization. You help the team with management, and you suggest ongoing discussions related to goals of care. You help to lead a difficult family meeting, and there is some disagreement among family members, leading it to be quite emotionally heated. During the meeting, you observe that the medical student becomes tearful and excuses herself. So this is a little bit less about the patient case and more about what you would do as an educator. So think through a little bit, putting yourself in the shoes and the mind of the medical student. How might you conceptualize what has happened with your student and what factors about this case or situation may have contributed? Again, we're going to pass around the mic, but any just kind of gut reactions to what the student might be experiencing, what they may be thinking about.
I actually wouldn't like to just assume that I know what's going on. I think asking is probably the better way to spin it.
That's
Because
great.
everybody has their own stuff going on.
Yes. And we're definitely going to engage the student in a discussion. I think just trying to imagine the student has left the room, you want to engage them in a conversation. What might the experience be like as a student? What they might be thinking about? What may have caused that reaction?
I also completely agree. Well, that was loud. I also completely agree with sort of going into it with an open mind and asking the med student, hey, what was going on? What was happening for you there? Let's talk about it. I want this rotation to be a very positive experience for you. I would also, in my mind, be thinking, well, maybe this med student is a very empathetic person. Maybe they're sort of, and this is, I'm not sure if this is an official term, but maybe they're sort of highly sensitive. And so they might be very in tune to what's going on during this family meeting. And that might have caused this emotional reaction. Or perhaps maybe there is a circumstance in the student's own life that might be causing some type of countertransference in this situation, in which case I might consider saying, well, maybe you can sit this one out, or maybe we need to process this a little bit more. Just two possibilities. There could be millions others.
Yeah, I agree with them about the not assuming that we know what's going on. I would say in that conversation with the med student, though, that I probably had the front end of it with a normalization of the response and kind of a, you know, a kind of explanation that it's common for these things to be very distressing, and they probably didn't expect that, and that yeah, it's frequent for many students to have a strong reaction to things like this, and then continue the conversation.
So I think what you're all hitting on, and which is, oh, one more.
Just wanted to put that last comment and kind of tie in the beginning where you said normalization can be a trap. So if you could help me put those two together.
All right. I'm not sure I understand that last.
So at the beginning, there was a slide where it talked about we can sometimes say, oh, this is normal for people to feel this way if they go through this experience, as opposed to realizing that it may have actually crossed the line to being a pathology or a response that really warrants either educational or clinical attention. I think that's what I recall.
Yeah, I think really helpful to keep all of that in mind, that there's definitely a range of responses. I think what you're all hitting on, and what we really wanted to highlight in this case, is that it's really important to have that open dialogue with your student, with your trainees, to kind of get a sense of how are they feeling, how are they responding to these difficult cases, and to think through how can you better prepare them as an educator, what can we think through in terms of helping them develop other coping strategies or ways to approach complicated cases. So in this particular case, we really wanted to highlight likely the student may be experiencing a countertransference reaction, that they may, possibly due to similarities between their ages or possibly other factors, they may identify with the patient or family situation. And that the student also in this moment may have been flooded. So they may have been overwhelmed by emotion and may have had some difficulty self-regulating in the moment. So again, just kind of helping our trainees is, again, taking a step back, thinking about what is the experience of a medical student, rotating on our clerkship, what does it feel like for them? And I think, just recognizing that this is a very difficult period. It's a time of transition. So they're shifting from being an observer to now taking a more active role in providing care. The issues of death and dying are, not things to be taken lightly. I think for many of us who've been in the field a little bit longer, they become part of our routine. We become, more comfortable with them. But for many of our students, this may be, the first time that they're really encountering some of these situations. So really helpful to keep that in mind as well. In addition, the idea that just learning to cope or regulate emotions under stress is a key skill. It's not something that most people are born with, and it's something that we have to actively work on and cultivate and encourage in our trainees as well. In addition, to recognize these early clinical experiences are, unique opportunities for learning. And so to try to use those opportunities when they come up to be able to better help our trainees as they progress through their training. So one concept I wanted to touch on, which I think was brought up as well in our discussion, is this concept of death anxiety. It's something that comes up in the medical education and the palliative care literature. It has been referred to as an unpleasant emotion that's provoked by contemplation of death in oneself or in others. It's usually triggered by intense contact with death or dying. It's multidimensional and it's existential in origin. It is something that occurs, on a spectrum. So there is some modest degree of death anxiety in any normal, thoughtful, sensitive person. If it's too low, that may be concerning, or it may lead to a casual or cavalier attitude towards life and death issues. If it's too high, that can also be problematic at times. It's been linked to maladjustment, neurotic symptoms, psychopathology. There may be some avoidance or procrastination, and either trainees or providers who have higher death anxiety may be less likely to engage or refer to palliative care or engage in end-of-life discussions. They're just helpful concepts to bring up, with ourselves and with our trainees as well. So some other discussion questions, and I think we started to touch on some of these as well. So what strategies can we utilize when trying to prepare trainees for these challenging situations? And how and when should students be educated about death, dying, and demoralization? So thinking through in our role as leaders, educators, helping to develop medical student curricula, kind of how do we bring up some of these topics, and how can we better prepare our students? Any thoughts? I think there's a hand in the back.
When I'm working with students, I actually use this as a opportunity to teach them about acceptance and commitment therapy, and that when people are struggling with death anxiety, it's thought, just like any other thought, and that we can apply diffusion exercises to that thought just like we would any other. And it also gives the medical student opportunity to practice some of these diffusion exercises, not necessarily with me, but a lot of times in order to be able to implement them with the patient, they have to be able to confront their own fears about it. So giving them the strategies to do that, and then connecting to their values as a provider, as a physician to be, so that way they can connect why they're staying engaged, right, with their values as a motivator, on why they want to sort of come into contact with the difficult emotions they have about that, and they can plan their own committed actions with the patient.
I think that's wonderful to, role model and to show them how do we use a lot of these therapeutic techniques that we advocate for in our patient care, and how can we use some of those and apply them to our own practice as well in our own self-care.
I think another thing is sometimes we wait to after things happen to talk about them, especially in education, of seeing the patient and then talking about them after. But sometimes talking about things before can be helpful, especially preparing. Because for a med student who's probably never seen a family meeting, or unless they've had someone in their own personal life go through something like that, has no idea what they're about to see. And so I think talking with them before about here's what a family meeting is, oftentimes they're emotional. There can be disagreement of setting things up before instead of waiting until after to talk about it.
Right. So you're a very smart audience, and I think offered a lot of really helpful suggestions that are in line with what we would recommend as well. Really the most important thing is to help students to become aware of their emotional responses, encourage them to seek support, to provide positive role modeling and mentorship, and to encourage both formal and informal debriefing, ideally both before and after the sessions, if possible. If you get a sense that we may be walking into a complicated situation, taking them aside, preparing them before you walk into the room, I think can be really crucial. In addition, these sessions are best if they're initiated by the educator. So many students will say that they, very much appreciate these opportunities, but may not have known that they were available beforehand.
These types of debriefing or support sessions can be very helpful for lessening emotional distress and bringing a sense of closure. In addition, if we think about that role modeling aspect, a lot of the times the students are looking to you as a more senior member of the team to compare their own emotional responses and assess, where were they appropriate? Could they be modified in any way? Are there strategies that you would suggest that have been helpful for you in your own experiences? And I think this, this experience, what the student went through, I think is very relatable. I think many of us have had similar situations, have had trainees who've had similar situations, and so helpful to just step back and think about what was helpful for us in those times. Okay. There are some challenges when we think about teaching about demoralization. So one, I think as has been brought up, teaching students about demoralization requires weaning them from the DSM, which still predominates our psychiatric education. So they have to start to introduce some other concepts that may be different from kind of the strict DSM criteria. In addition, students often become very uncomfortable pathologizing distress, so helping them to recognize that discomfort. Students may be very hesitant to apply what they perceive as a possibly stigmatizing label to people who are already suffering a serious medical or psychiatric condition. And so helpful to show them, how just recognition, acknowledgement of this, as a diagnosis can be helpful in coming up with strategies that will hopefully aid the patient and the team going forward. Before I get to this, I just wanted to reflect on how there's, demoralization, I think, affects multiple layers, not just the patient, the family, the team, you as providers, but also many of our trainees who depend on us and who look at us for advice. So one aspect that I wanted to touch on briefly was just demoralization in COVID. And during the pandemic, demoralization has, had increased attention. I think that, the pandemic has affected the healthcare system in many ways. It's been, a really difficult time. I think there's a lot of concerns there have been a lot of concerns for safety, concerns about staffing shortages, inadequate support, a lot of ethical challenges, that idea of moral injury, having to make these really difficult decisions with limited resources. And, kind of seeing the toll that takes on our colleagues and our institutions and ourselves. So again, just an open discussion question. So what have you personally witnessed or experienced with regards to demoralization over the last 3 years? And what can we do about it as CL psychiatrists in our role as leaders and as educators?
From my perspective, and I think the cases illustrate this, existential distress and demoralization is part of the human condition. And normalizing the wide range of painful emotions that come up with those experiences is part of educating to emotional intelligence. That kind of answers your question you asked me earlier, which is that when I work with folks with these scenarios, I do highlight that as much attention as we give to developing our emotional intelligence of others, we also have an opportunity to develop emotional intelligence about our own experiences and feelings and to normalize them as part of coping with existential distress. I do think in the last case, it makes me reflect in part because so much of my clinical work is taking care of physicians at how often we think of our trainees as the ones who are experiencing their own existential distress when they see death and dying in a very intense way. My own experience, and I guess I would make a call out to us as CL psychiatrists, is how many of us are seeing demoralization in our senior peers or our colleagues that are our age. I think that demoralization for some of our physicians and COVID, I think, has highlighted this, has actually snowballed for a number of reasons, such that I'm seeing levels of demoralization in physician care that I have never seen in my 25 years of practice. So I think this is a very compelling question, not only for taking care of our patients with normal existential distress, which risks their illnesses, but also amongst ourselves, no matter where we are in the developmental spectrum.
Hello, thank you for the talk. Oh, sorry. I think I have a question maybe for the speakers and audience. So what I observe is like there are, I think it's kind of a double-edged situation. Many of the non-psychiatrist providers, sometimes they don't feel like they need to consult at all, and they just start an antidepressant for a patient with demoralization or Zyprexa PRN, Haldol PRN. And I think this is one part that we sometimes miss, that we need to like maybe educate the non-psychiatrist teams as well about demoralization. And I just wonder like what kind of like ways that you use to like, you know, educate other teams. And other question that I want to ask, I think, yeah, it's ideal for CL psychiatric team to do ACT or brief psychotherapy, but sometimes we are burnout as well. And sometimes we are slammed by high volume of consults, and it's become sometimes impossible, I think, to, you know, like sit with the patient and do like long run therapy. I mean, I just wonder, do you guys have other tools or team members like counseling teams, psychotherapists in your team? I just wonder like what kind of, you know, tools or other team members that you have to assist you in terms of this as well. Thank you.
Sure. So if it's okay, I'm going to save some of the questions. We have time for a Q&A session a little bit later, but please let's hold on to that and we'll definitely get to those questions as well.
So to have you run over here, Damien, I'll just talk into this. So I think I was sitting on the plane yesterday coming here next to another person coming to the meeting. We were talking about kind of demoralization and burnout in healthcare providers and kind of our institution's responses to it, and things that don't make sense to us as psychiatrists who work with this, like having a donut truck show up once a week to give free donuts doesn't necessarily help with demoralization. So I think our roles as CL psychiatrists is to help our institutions kind of think through what are the interventions or approaches that they're taking, to have them be based on things that work for demoralization than things that just momentarily may make people feel better because you get a free donut. So I think our role is to be involved in kind of institutional responses to this.
I like how the fourth case does focus on the medical student kind of going outside the silo of patient. I would add that kind of something that I've experienced, I suppose, is that it seems less frequent that it's the med student, more frequent that it's nursing or family members that have strong responses with the kind of contagion, demoralization. I think as that's part of liaison work with CL psychiatry and a demoralization scenario to try and navigate that with folks.
I absolutely agree. I think it could affect, any member of the team. I think for the purpose of this talk, we just tried to hit a few different levels. So the fellow, the student, the family, the team, but definitely I think a lot of folks are all experiencing countertransference reactions, their own demoralization reactions. It's a complicated scenario, and I think it draws out a lot of emotion. So I think a lot of the same strategies that we would use, with patients and with ourselves or with our colleagues, I think can also be applied to family members, to nursing staff, to other members of the team as well.
So I know with COVID, a lot of institutions implemented services and more awareness for staff members to seek help. And, our psychiatry department, became accessible for nurses and other physicians that needed help. We had a hotline and, all these kinds of things. And I think hopefully, if anything, that will help us learn that we need to keep that going. That should be something that's in place for all the time, because it's always needed in this kind of work that people do.
Yeah, I liked your comment. I also just wanted to build off some other comments about like a range of emotional responses in ourselves and demoralization in ourselves. I think we have a role to like model vulnerability in some ways too, especially with our trainees, because I feel like it's pretty hard to, if we as more senior people are like asking a med student, how did that make you feel? It might kind of make them feel on the spot unless we also preempt that with like in the past, I've had X emotional response. So I wanted to add that and like, I think it can help model the process of self-reflection so that you're not like enacting, a counter-transference or, yeah. So I want to say that, and then also discussing like, what are the signs that you maybe should seek more care, like go to employee health or whatnot, having persistent intrusive thoughts or something like that.
Well, thank you everyone for the interactive discussion and really appreciate all of your thoughts. I just wanted to add, so these are just some summary take-home messages. I'll allow you to kind of read them for yourselves, and then we will open up for question and answer. We did include a lot of helpful references related to this topic, so for future reading. And now I'll invite my co-speakers to come up and we'll do the Q&A if that's okay. Wonderful.
So we have one microphone up here, and I'll put the other one just on this side. If you guys have any other questions.
So to circle back to the question about like resources for addressing demoralization when, you're running a very busy service and don't necessarily have time to sit and go through like psychotherapy with a long list of patients. I think, of course, hospital social work is available, but also being fortunate enough to have a psychologist on staff who can help with those selected kind of most challenging or most in need of more in-depth kind of advanced psychotherapy has been a tool that is new, I think, to us, but has proven very helpful. I don't know if others. I think one other thing I thought to add in thinking about your question was about like the nursing staff and their experience of like the flooding of emotions or emotional reactions. Thinking back to the case that I presented, there was quite a bit of disagreement amongst kind of the nurses caring for the patient. Physical therapy was also asked, get the patient up, push her, she needs to walk. And they really felt strongly like she can't do these things. She's physically not able. And so ultimately getting ethics involved to help have a conversation with everybody about what are our expectations of each other, of the patient, was a really helpful way to kind of move past some of the like emotional expectations or like emotional reactions, the frustration, and be in the same place about what we were hoping for this patient. I don't know.
So I'm sorry I'm talking a lot, but I'm literally shivering, and so I'm getting up to move around and talk to keep warm. So other resources could be palliative care. I think palliative care is very good with some of these conversations. And so even though they may not do psychotherapy, they can broach some of these topics with people and have long conversations with them. And then also chaplains could be useful too, of maybe talking with the chaplain first about kind of your conceptualization of the case, and then having them talk with patients about meaning and existential issues could be helpful too.
I agree. I think leveraging the team that you have around you as much as you can is really helpful, because you can only do so much as one individual member of the team. But there's trying to recognize who is on your treatment team who could help with some of these questions that patients deal with. And I think another thing that I often fall back on, especially if I'm only going to meet with a patient 1 or 2 times on the inpatient unit before they're discharged home and continue their care outside, is just falling back on psychoeducation as much as possible and talking with them a little bit about what they can expect. Getting a little history from them about where they are in their treatment is always helpful. And this is another area where it's helpful to be a subspecialist and kind of know your disease a little bit more and know what patients go through, whether it be, for us all psycho-oncology, but like cardiac psychiatry, having an understanding of what patients go through can be helpful. So I talk with patients a lot who are at, if they've just been diagnosed, what to expect after they've been diagnosed. What times in their treatment course might there be like extra anxiety, or there going to be periods where they could, you would hope that they wouldn't have any setbacks, but if that happens, like what would happen next medically, and then what they might, experience emotionally for themselves and also for their team, for their family as well. And I think there was a question too about how to engage the medical teams a little bit more on recognizing demoralization and understanding that it's a problem. I think this is a small thing that I like to do, but I think the overarching summary would be just reminding the team that the patient is more than just sort of what they're seeing in these 2-week ICU course or 2-week medical admission, that they have a whole story behind them too. So reminding them that, like my one-liners, I might sometimes write oh, this is a 60-year-old, instead of 60-year-old woman, saying like a 60-year-old mother of 3, retired, chemist, painter, something like that. So to give them a reminder of that this patient has a lot going on outside of just the labs and values here. And I think they know that too, once you remind them and prompt them, at least the providers that we tend to work with. But I think it'd be helpful to kind of remind them, that there's a lot that this patient has heading into the submission already before, all the setbacks that they may have experienced, well, I say admission, but in general.
Just wanted to comment, social determinants of health and doctors, that can affect doctors too. I can't think of how many Zoom calls I've been in, and particularly female physicians where there's kids in the background and, trying to juggle household stuff and kids not having school available to go to and still being expected to be just as good as in terms of your clinical care as any other situation. And, also getting hit with family members coming down with COVID. I mean, these are more problems without solutions in some cases, but it's been a real issue.
Sorry, can I jump in? Thanks. Hi, thanks for the presentation. I have a question actually similar to the other question around service, but around learners. I'm an earlier career psychiatrist up in Toronto in Canada. And I think one of the burnout problems that we also face is our trainees seeing a lot of cases and consults around demoralization and feeling sort of like having to go to the consult, but not having the resources and time to do the psychotherapy. And then feeling sort of helpless and also purposeless and having to do the consult without finding much meaning or learning. So curious if there's other folks who have encountered this and if there's strategies with helping them, because I try to be nice on ECP, so sometimes I save the consult for myself at the end of the day, but I wonder if there's other ideas.
I just say, I think some of this goes back to what John Petit was commenting on, just the way that a lot of our students and residents are trained is, I think the way that oftentimes psychotherapy is introduced, it's taught as, something that's a very formalized thing that has to occur in these very structured settings. And I think as CL psychiatrist, it's about, trying to, break that down a little bit and find ways to introduce therapy and in a time limited encounter, using the tools that we have without, maybe sitting down for an hour every week with the patient. So getting to know the patient, the family a little bit better, helping them to recognize what are their strengths, what are their values, what are the things that really help, keep them going, and replacing some of that helplessness and hopelessness, with the things that they already have or the things that were helpful for them in the past.
Yeah, and I could respond to that too a little bit. I think sometimes in those encounters, even if they're brief, and just then talking with the medical student afterwards and reflecting on, why you said what you said, why you didn't say something else, et cetera. So that can be something in a sort of very, very sort of short period of time to really show them that you can deliver a sort of psychotherapeutic intervention, briefly, and also how it can be appropriate for wherever the patient is. I mean, that's sort of the idea. I wanted to just comment on the medical student education part, because I thought, in listening to this wonderful presentation about, I think this probably works better in the clinic, frankly, but let's say you're having a difficult conversation or the patient is emoting in some way, and really reflecting with the student about what the feelings are that are brought up, and actually this kind of self-other sort of diffusion. I really don't think it's possible to carry on with death and dying and patients and whatnot without reflecting on your own mortality and what you have dealt with in your life. It's just not possible. I don't know if everyone agrees. That's my opinion. And so, especially with medical students who are starting into this area, it's very rich to have an experience where someone just, an attending sits with them, whatever amount of time it might be, and really sort of explains that. And sometimes I've even gone to the extent of explaining the ways in which it happens for me in a very personal way, and going over, for me, most saliently would be the death of my father. And so I will explain that for me, because I'm also an oncologist, so I treat patients with lung cancer. And it was very salient after my father had passed that, seeing the very routine sort of day-to-day issues that come up, having end-of-life conversations several times a week, et cetera, or even, a tough day, right? But at that moment, it was so clear to me that where that line was, because it was so strong. It was, my dad was a smoker, right? The smell of smoke, I'm out of the room. I'm dealing with my emotion, that's it. But wait a second, I just had this conversation, right? And I think I was empathic in that conversation. I did a good job. In fact, I did a better job in that conversation. I'm a mess in this conversation because all of that emotion is my emotion, right? And so, there's not a good way to get at this necessarily, but I think you plant that seed where you start to say, look, you're going to have emotions here, and maybe you need to think about, and we need to think about, I'm not going to be this medical student's therapist, of course, but it's something that they should start thinking about, because to have an idea of what is your emotion versus, hey, wait a second, what is this patient actually feeling? I think is a gift, frankly. The other side of it is continued curiosity. We don't know, right? And that planting that seed in the patient is also key, because obviously the default is, I think they're feeling this, right? We don't know. You just have to keep pushing that. But I really don't think without that clear line of self and other, we're going to be effective. There's just the bottom line. And I can tell you, in my good days where that line is right there, I am effective. If for whatever reason something's going on in my life, if that line's not there, I'm not effective. It's just the bottom line. Anyway, if we could get that message to students, it'd be great. Thank you.
I think that point about, you guys hear me? Yeah. I think that point about curiosity is really important because I think it can be very easy on any medical, whether it be oncology, nephrology, wherever the patient might be, clinic or outpatient, to fill in the blanks for the patient too, and sort of assume what their experience is. And I think for a lot of our patients, they deal with that every day with a lot of the providers. That providers like, oh, it must be like, you must be frustrated because of X, Y, or Z. I think it can be really helpful to stay curious and make sure that the patient has their own space to kind of to share their story and to tell you as their provider about what they're going through instead of just sort of assuming. And it can be, I think, helpful for patients too, knowing that that does happen through most of their encounters, whether it be for time or just for any number of reasons. I think we're out of time. Thank you all so much for coming and participating. We really appreciate your attention and participation. Thanks so much.